Well, that was a very, very long round of applause for you, Dr. Calhoun. I think it says a lot for your speech, and it was very positive and very, very informative. Thank you very much indeed to all of our speakers today. I'd invite our afternoon speakers to join me here on the stage. And we're going to proceed with our questions and answers session. So I'd invite questions from the floor. We're going to have a roving microphone with Rebecca.
Thanks very much to all the speakers. John Birmingham, obstetrician, Waterford. Could I ask Dr. Calhoun to comment on the use of antibiotics if he suspects that he has had a premature rupture of membranes? And the reason I ask is there is some doubt that if you feel that the membranes have resealed, and I must say it's a concept that I find very difficult to believe, there is some evidence that the use of long-term antibiotics with intact membranes, which were used very liberally for a while in so-called threatened premature labour, there was some evidence that long-term erythromycin had a cerebral palsy effect at up to 7 years of age follow-up. Would you comment on that?
Well, that's actually a very good question. And what we usually do is about 48 hours and then get cultures. And what we've really probably found is that, as Dr. Chireau talked about earlier, is my mic on? Oh, this one? I'm sorry. I'm sorry. I couldn't tell, so it wasn't on. What we found is we use 48 hours of antibiotics until we get our cultures back. And as Dr. Chireau had pointed out with some of the preterm delivery data and Gardnerella and some of the vaginitis previous literature, is that probably what we were doing was with the erythromycin selecting for organisms that were resistant. So we treat for 48 hours only, and then we would, if there's positive cultures, may treat for up to a week and then no more. And at that point, we've not seen, in our experience or in the literature that I've read recently, without long-term antibiotics ill effects with using those in premature rupture of the membranes or long-term morbidities with that, since we assume they're already infected with premature rupture of membranes, as you pointed out.
The gentleman over there.
Just one quick question to Dr. Priscilla Coleman for the mathematics. I didn't understand 130% and 250% for the statistics.
In terms of the increased risk?
Increased risk to patients who have abortion for alcoholism and depression. What is range of 53 to 180%? What does 180% mean?
It depended on the particular comparison, but in the meta-analysis, I compared women who had had an abortion to women who had an unintended pregnancy delivered, or they had not had a reproductive event, or they had a pregnancy that was delivered and it wasn't identified as unintended per se. So it's a comparison. There's the increased risk of 53%, for example, is compared to the unintended pregnancy delivered. So the risk of having a mental health problem across one of those categories of depression, anxiety, substance use, suicidal behaviors, it was that much greater for the women who had had the abortion.
So if mathematically I am correct, does that mean when we say 53% that we decreased the incidence of alcoholic, or what? Well, I believe 100% is one. So how to get more than one per person if we talk right? If we're speaking 53%, that means she was 100 and she became 53, so she's less alcoholic, or how she will become 180%? Well,
it's a group type of an analysis, so we're dealing with larger numbers, and overall we're comparing an enormous, really, in a meta-analysis, we're pulling data from 22 studies. So in general, an average woman who has an unintended pregnancy delivered, her risk would be considerably lower than a woman who has an abortion. It's 53% higher on average in that group of women who have aborted. But we also calculated the population attributable risk, which came out to be 10%. So that means that if we look at the incidence of mental health problems across the board, 10% of them are directly attributable to abortion.
But per person, how you reach more than 100%? Per person, how much you reach more than 100% risk?
I guess I'm not understanding the question.
Okay.
Because it's a group comparison. It's really can't look at the individual. Yeah.
The gentleman in front of you, actually. Okay. Just first, thank you. Yeah.
Good afternoon. Thank you very much for very interesting talks. I had a question for Professor Koch, actually. Professor Koch, I was very interested to hear that the law was changed to make termination, ban terminations in Chile in 1989. In Ireland, as you are aware, we have up to 7,000 women per year traveling to the UK to have their terminations over there. 4,500, thank you for correcting me there. Very pleased to hear it. Whereas in Chile, I wonder what's the situation now. Where do women go? Do they go to Argentina? Do you capture them all? And what percentage of women would have a backstreet abortion outside a recognized health facility? And do you have data on their health outcomes?
The question is basically, since Chile has outlawed abortion, where are many people going for backstreet abortions, or are they traveling elsewhere to procure an abortion?
No. The case in Latin America, most of the Latin American countries have restricted abortion laws, and it's very difficult for women to travel to inner of the Latin America, South America, in order to carry out an abortion. That is not similar to European countries. Here, women can travel and other nearby countries in order to carry out abortions. But clandestine abortions or induced abortion is not ever unsafe, because unsafe abortions and illegal abortions is not the same, because unsafe abortions is related with high morbidity and mortality by abortion. But in most of these countries, maternal mortality by abortion is reduced, had been reduced in the last 10 years. In Chile, practically abortion mortality is eradicated. But all abortions in Chile, induced abortions, are illegal. Illegal abortion. But you can say that these abortions are unsafe. If we observe in the graphs, the trend is decreasing. And the trend in abortion mortality practically disappeared. The question is, what is the effect of abortion restriction on the rate of induced abortion? I think that increasing education level in poor countries, and in Chile, for example, increase the ability of women to control their own fertility. And this phenomena possible reduce maternal mortality and abortion mortality simultaneously. Another problem is the effect of legislation. We rule out any causal effect relationship between, from the public health perspective, from the collective perspective. We were ruling out any cause effect between legal status of abortion and maternal morbidity and mortality, including abortion mortality. That one argument to legalize abortion is clandestine abortion, not backstreet abortions. But with legalization, you cannot eliminate absolutely clandestine abortion, depend of the law. For example, abortions with a limit of 12 weeks is allowed, but all abortions over this limit are illegal. Another question is the legalization abortion or does have the legalization of abortion the ability to reduce the incidence of abortions by itself? Not. Abortion increase, and abortion is used by a substantial proportion of young women as a method of regulation of fertility. That is the case in Europe today. But in countries in South America where abortion is prohibited, this phenomenon don't occur. Regarding maternal morbidity and maternal mortality, our registry today is one of the more complete in the American continent, because every maternal or infant mortality is audited by the sanitary authority in the country under strict confidentiality rules. Doctors in Chile report maternal deaths or complications by abortions. They have no problem because they are protected by the medical professional secret and the rules of confidentiality to the medical-patient relationship. I think that the Chilean data today allows to rule out the effect, any effect of abortion prohibition and on maternal health, and I have the data are enough reliability to conclude this issue. Maybe one or two cases can be lost, but it's insignificant from the statistical perspective. It's not the case in all South America. Chile is the referent from the Organization of Economic Cooperation and Development. The Chilean Institute of Statistics is the referent for all Latin America because have the better registry of vital statistics in this continent.
Okay, thank you very much, Dr. Koch. The man behind you there, please.
Thanks very much. It's Okapan, Loudmate Hospital Group. My question goes to Dr. Monaghan. And during your presentation, there was an interesting slide which showed a lot more of the young medical graduates tend to be attracted for training in the northern part of the country. And I just want to ask you, why don't we have a similar situation in the south where there is no abortion? I think the reason you gave was that there is no abortion in the north. Therefore, a lot more of the medical graduates tend to be attracted for training up north compared to the rest of the UK. We do not seem to have a similar situation in the south here. I said that because I work in a department where you have 7 consultants, 7 registrars, 7 SHOs. Now, over the last 4 to 5 years, we have come to depend on GP trainees as opposed to the career training. How do you explain the situation in the south?
I can't really. That's why I didn't mention it. I think one of the suggestions about the situation in the UK is that because of poor recruitment, training was shortened, or one has the impression that the facilitated training, particularly maybe for women who are trying to raise a family as well as do a career, that the period of training shortened, and that may have something to do with the apparent rise in maternal mortality. No, I wasn't saying that people were going from outside into Northern Ireland. Maybe I misheard you, but I think it was just that the graduates, I was suggesting that graduates in Northern Ireland were more attracted to a career in obstetrics and gynecology than they were on the mainland UK. Are you saying that your hospital, like my hospital, most of the trainees are not Irish people? Is that what you mean, or that the trainees are GP trainees? My hearing is not perfect.
No, I'm saying that we seem to have seen a decline in the number of people taking up obstetrics here. And it may not be the situation in the Dublin hospitals, but certainly in the other hospitals outside here. And you find that at the SHO level, there's a decline in the number taking up obstetrics and gynecology.
I'm sure there's an easy answer to that question, but I don't have it. Now, one of the possibilities is that over the last 10 years or so, the number of trainee posts has expanded, particularly registrar posts. Certainly there would be probably 2 more registrars in our hospital than there were before, and it's much more difficult to fill those posts because there aren't Irish trainees available. But whether recruitment in Ireland as a whole has dropped or not, I can't answer. I have a slight suspicion that it may have dropped a little bit.
Okay, we're eager to wrap up. There's just one more question, if possible. The gentleman near the back there. I know you're all eager to get home and out into the sunshine.
It's not really a question. This gentleman over here said about women, Irish women going to England for abortions, and the figures. These are not figures of Irish women going to England for abortions. They're the figures that the British abortion clinics say are Irish women. Now, there is some evidence that some of the abortion clinics, because they have to go through a procedure to do an abortion on an English woman, register English women as Irish. So then usually we hear it the other way round. The pro-abortion people say, oh, there's only 4,000 register, the rest give English addresses. But apparently English women will give Irish addresses. Thank you.
That's very interesting. Thank you. Well, just one more question. That's the very last question. Thank you. And please keep it brief. Thank you.
It will be very brief. Thank you all. Thanks for everything. Now, this question is for Dr. Monaghan, please. What would be your views on the morning after pill and the effect of that on recruitment, especially in general practice in the coming years? Thank you.
I haven't really thought about the morning after pill. For obstetrician gynecologists, I don't think it's a big issue because they don't have regular contact with it. I think it falls to general GPs or accident and emergency departments, the issue of morning after contraception. Does it affect recruitment into different specialties? Is that what you mean? As in particular general practice?
This country, in the north, they're not looked up. The abortion issue is not there. That's why you have more recruitment in obs and gynae. But over here, or even in the UK, the morning after pill is given by all the GPs up to 72 hours after unprotected sex. So that might be an issue in a lot of doctors' minds, that should we do it or shouldn't we do it?
Yes.
And they might say,
yes.
Say it again, yeah, it's given the pharmacies, yeah, that's right, it is given the pharmacies. Is it available in all pharmacies? All right, because I face a lot of patients coming to me for the morning after. That's why.
Okay. Could I take that discussion privately amongst the GPs and yourselves after this, please? We're trying to keep it flowing and on time. Could I also mention that if there are any CME forms in front of you that you're not using, could you please bring them back out to the registration desk? Please don't forget to collect them on your way out. I'd very much like to thank everybody for coming here today. I think it was a very fruitful exercise. I'd like to thank the organising committee and wish you a safe home. Thank you very much.